give a drug-free holiday after 3 to 5 years of use, and the holiday can be 2 years, 3 years, or 5 years, as you deem important or according to the patient's need. So to conclude, oral bisphosphonates have led to decrease in osteoporotic fractures globally. Strong evidence supports drug holidays for most patients after 3 to 5 years of continuous bisphosphonate therapy. Yet there is a lack of evidence about the length of the drug holiday to be given. The appropriate duration of a drug holiday is likely affected by the initial length and concentration of the therapy, drug retention pharmacology, BMD and the fall risk, and the patient's characteristics like the skeletal size. Future research is needed to examine the fracture risk by drug holiday length that considers how these factors modify fracture risk to form patient and therapy-specific drug holiday timeframes. Thank you so much.
Thank you, Dr. Pushpa, for giving us so much a good lecture. Thank you so much. Dr. Samu, the next speaker.
It's my pleasure to introduce Dr. Pooja Paul. She is an otolaryngology specialist, and she also serves as a council member of the Otolaryngology Society of Sri Guru Ramadas Institute of Medical Sciences and Research Center, Amritsar. Ma'am, we invite you to talk about thyroid and bone health. Over to you, ma'am.
Thank you, everyone. I hope I'm audible. At the outset, I'd like to thank the organizer of WOICE, especially Dr. Aarti, for giving me this opportunity to address all of y'all. And like Dr. Pushpa mentioned, it's literally like teaching to the choir about osteoporosis. And I've been given 4 minutes to do this job, which is next to impossible, but I'll try to do my best of giving a brief overview. So coming to the role of thyroid and bone health, now weak bones have often been attributed to a reduced levels of calcium and vitamin D, like we have always been taught. But a very important factor which we ignore and which we don't address often is the role of thyroid hormones in the bone health. And this is especially important, especially among Indian women, because this is a picture which we unfortunately often see. And Indian women, they often don't address this issue. They don't seek treatment for thyroid disorders for various reasons for many years. So hyperthyroidism is an important cause of secondary osteoporosis, and which is an extremely common condition in India, affecting almost 80% of Indian women. Even if you look at the fractures which are associated with osteoporosis, they are twice as more common in women as compared to men, which makes it an extremely important issue which has to be looked into. So if you look at hyperthyroidism and thyrotoxicosis, the first report was by von Recklinghausen back in 1891, and this patient eventually succumbed to his disease. One of the commonest causes of hyperthyroidism is Graves' disease. And what happens is there's an excess of thyroid hormones which affects the metabolic systems of the entire body, affecting the CVS, CNS, and other systems, including the skeletal system. And there's a direct catabolic effect on bone mineral homeostasis, which leads to an increased bone mineral resorption and a loss of calcium through the kidneys. Like I've already mentioned, it is an important cause of osteoporosis. And there was a study which was done by Uday Kumar et al. In 2006. And among his study population of hyperthyroid patients, he found that there was an incidence of osteopenia in 32%. And the rate of osteoporosis was as high as 60%. So it is extremely common in patients of hyperthyroidism. But what was very important and which I think is really relevant is that there was a reversal of bone loss after initiation of treatment. So this is a reversible condition. This is one of the treatable conditions that we can use to help patients with osteoporosis. Another factor which complicates this issue is the concomitant presence of vitamin D deficiency. And Graves' disease can be associated with a vitamin D deficiency, which is again twice as more common in females as compared to males. This is probably because of a reduced intestinal absorption of vitamin D due to steatorrhea as well as hepatic enzyme induction. Another entity which we need to be aware of is subclinical hyperthyroidism. Now, this is a condition in which the levels of T3 and T4 hormones are normal. However, the TSH levels are low. The incidence in women is around 15%. It's a subtler disease. The patient is often asymptomatic, doesn't have any symptoms, and it is diagnosed during a routine screening. So this attained attention a couple of years back because it was associated with a higher risk of atrial fibrillation, especially when the TSH levels fall to less than 0.1. It can be associated with reduced bone mineral density as well as an increased risk of fractures, especially in cases of females, especially postmenopausal. And it was also seen that in women over the age of 65, the rate of hip fractures was thrice as more common, whereas there was a 4 times higher risk of vertebral fractures in patients if the TSH levels were low. So I think this is again another very important factor which we don't look into, and it is a treatable and a correctable condition, which will definitely help the women's bone health. Hypothyroidism is a condition which is completely different from hyperthyroidism in terms of all signs and symptoms, except when it comes to bone metabolism. There is a reduced osteoclastic and osteoblastic activity, which leads to an increase in bone density. But unfortunately, the quality of bone is poor. So that is why, like hypothyroidism is also associated with an increased risk of fractures. So ultimately, both hyper as well as hypothyroidism are detrimental to the bone health in general. So to conclude my very short talk, with the changing worldwide geographic occurrence of bone disorders, it is important to remember thyroid hormones and hyper as well as hypothyroidism as a secondary cause of osteoporosis. Reduced bone mineral density in thyrotoxicosis is reversible with treatment as soon as 1 year after initiation of anti-thyroid therapy. In Indian population, this problem has a synergistic effect with the deficiency of vitamin D, which aggravates the bone loss. And even in asymptomatic patients, if they are diagnosed to be hypothyroid or hyperthyroid, regular medications as well as periodic checking of thyroid hormone levels is essential to maintain bone health. Thank you.
Thank you, Dr. Pooja Pal. Sticking to the time.
I tried my best.
Yeah, thank you so much. So we can start a panel discussion, and if there's some IO officials, so they can address. And thank you, all of you, for giving so much time on this day, International Women's Day, and Holi, because it was a holiday and it was tough for like me to collect everybody, but still everybody tried, and thank you so much. So we can go for a panel discussion, Dr. Samu.
Yes, ma'am. We had a wonderful speakers from all over the globe with the introduction of various specialties, including gynecology and ENT, and we got wide knowledge of how we can better treat osteoporosis by understanding the importance of vitamin D and how early in a menopausal woman we can treat osteoporosis. Also, the role of thyroid and ENT. Quickly, we can have a panel discussion with our panel members. Request the esteemed panel members to take over.
Happy Women's Day to everybody. Dr. Shobha, can I ask you a question? That is there any specific kind of exercise that boosts the immunity of the T cells, or any generalized exercise would do that? Like, is it a cardio, muscle building, or maybe just walking or something like that? Dr. Shobha, ma'am?
Yeah. Actually, the role of T cell is related to angiogenesis. They have said that exercise gives rise to angiogenesis, new angiogenesis, because of periosteal activity to which the muscles are attached. However, this angiogenesis is not same as hyperemia. Therefore, this angiogenesis indirectly causes increase in the T cell population, which is still a matter of research. Exercise, how it affects the bones, is still under research as far as the immunology of bone is concerned. But all in all, the T cell population definitely increases with exercise. That's a wonderful thing.
So I have a question for Dr. Usha, Dr. Emel, and maybe Dr. Pushpa. Each one of you could take this. So what would be the difference for choice of drugs in a perimenopausal woman and a postmenopausal woman? If regularly a woman had to take certain medicines like a vitamin D, calcium, then what would they be in either of the situations? So if each one of you could just give a quick guideline which can be used in daily practice by everyone, that would be nice.
I may suggest 1,000 international units of vitamin B and plus calcium 500 milligram, and that's for all adult women. If the vitamin D levels are sufficient, which means above 50.
And any role of calcitriol, like we didn't discuss about it, so it was just specific. Yeah.
Sorry.
Hello, everybody. Am I audible?
Yes,
Yes,
you're
ma'am.
audible, Dr.
Yeah,
Mehta.
I just have one question for the panelists, for the speakers. Actually, after the discussion, what has been made clear is that osteoporosis is one of the silent killers, I should say, as we all of us are afraid of hypertension and diabetes, but especially when I'm dealing with elderly people, I think it is one of the silent killers in elderly people. So, as Dr. Shriram ma'am told that the screening for osteoporosis, usually we don't do it in your usual practice, that is usual practice, because it's DEXA scan is not present everywhere and it is a problem. So, as she said that it should be done in after 55 in females, and maybe with all the females who come with the fracture. But are there any some guidelines from your society, from Orthopedic Society of India, who recommend some some other criteria for screening all patients of without symptoms, all postmenopausal females, or some age group is there?
No, actually, there are no such guidelines. That's what I was trying to understand from y'all. That what do we do for the perimenopausal? Because how the bone strength is probably before attaining menopause would make a lot of difference post that. So that's what I wanted to know. That could we make the bone health much better before we just like trying to go towards osteoporosis before the onset of it? So we don't have as such any guidelines for screening. And like Emel mentioned, like the daily supplements which people take, usually that is one of the regimes people follow. Otherwise, the weekly into 8 and along with calcium is something what we routinely prescribe as orthopedicians. But yeah, nothing for screening as such.
May I
Can I take
interject here,
on? Yeah,
ladies?
please.
May I interject here, ladies?
Yes.
First and foremost, I welcome you all on behalf of the Indian Orthopedic Association. And the reason I'm interjecting here is because, unlike what probably is known to you, the theme this year by Dr. Atul Srivastva is Strong Bones, Stronger Nation. And we have a very, very strong committee led by Dr. S.S. Jha and Dr. S.S. Amarnath, who are working towards making these guidelines, exactly what you women are discussing. And it will be great if the voice actually joins hands. And we do have people, the seniors who are non-orthopedic surgeons here. We are taking inputs from Dr. Usha, Shriram, and many other people, in fact, including the Indian Menopause Society. So having said that, we are working towards it. And the point which I've been a party to this entire discussion. One is we need to concentrate on women building their peak bone mass, PBM, at a much younger age, which is what you need to women push it. 25, 30 is the age group where you get your calcium and D3 in, and not wait till 45, 50. Next, I strongly recommend not overuse or misuse of DEXA in the perimenopausal or premenopausal phase. We have innumerable number of women who can be getting low T scores and normal Z scores, but are initiated on treatment premenopausal, which I think is an overkill. The other thing which I'm now making a statement, which is purely based on conjecture and experience and less on validation, is that very rarely can you get hypervitaminosis D3 with oral therapy. I repeat, very rarely will you get hypervitaminosis D3 with oral therapy. Throughout COVID, I have used 60,000 IU twice a month as a maintenance dose, unlike pre and post COVID, where it is 60,000 IU once a month. Overseas, and the international faculty mentioned, their maintenance dose is 30,000 IU. which is 1,000 per day. In our country, we need a minimum of 2,000 IU per day as a maintenance dose. But even if we are using 60,000 twice a month, which is 4,000 IU per day, we very rarely will go beyond 100 nanomoles. Plus, hypervitaminosis is not toxicity in vitamin D. And our Indian women are generally weak and low in calcium and D3. Hence, I would strongly recommend that don't just look at 30 as the cutoff, look, as very rightly mentioned, as 50 as the cutoff, and work towards getting vitamin D up. I mean, I have the right to say this because I've celebrated my mother's 100th birthday yesterday. All right. And she's 100 plus and walking around. The only thing I've stuck to is giving her calcium and vitamin D3. She's way beyond the anti-osteoporotics that we've used, whether it was bisphosphonate, teriparatide, or the works, but she's only been on this. So just get your calcium D3 in place, and you women live longer than men. And I'm sure that you will outnumber us very soon. So it's great. Please keep it up. And I love the entire discussion. Thank you for having us here.
Thank you, sir.
Thank you, Ramchandra.
Aarti, may I take a second on answering that question on a simpler
sir.
way? DEXA is not recommended routinely. That's very clear, obviously. One simple investigation that we used to use in AIMS Rishikesh was that take a good quality digital X-ray pelvis. Flat bones are the ones to show you osteoporosis at the earliest. And even if there is no osteoporosis, how do you judge the bone quality? It's not the femoral head. It's the Gothic arch, which is the superolateral part of the acetabulum, which forms a Gothic arch. And we are all conversant. It's right from our PG days, we are able to look at the Gothic arch. The trabecular concentration per unit trabecular concentration in the Gothic arch is the one that gives the idea of osteoporosis or osteomalacia also beginning there. Don't look at the femoral head. Femoral head comes much, much later. So the Gothic arch, plain simple X-ray pelvis, and look at both the Gothic arches. You have an impression of a normal Gothic arch, and the lessening of number of trabeculae in the Gothic arch is the one indicator whether you need a DEXA or not. That's what we have been following.
Thank you, Dr. Shobha, ma'am. So I think so. We can.
Yeah.
Sure.
Yeah, I would like to thank the organizers for having a great job done by organizing this webinar. And thank you for giving me this opportunity as a panelist. And rightly said by Dr. Ram sir, that all the questions of at least my questions were answered, and he summed up all the lecture in just one go. And thank you so much. The speakers were amazing, especially Shobha ma'am and Emel and everyone else. Thank you.
Thank you, Dr. Ravisha. So I think so because we are running short of time. Dr. Rujuta ma'am, she is there. Dr. Rujuta ma'am, thank you so much for joining us, and thank you all the speakers, panelists.
But I'm sure you all did a wonderful job.
Thank you, ma'am. That's your inspiration, Shobha ma'am's inspiration, Dr. Emel, Dr. Chasanal, Dr. Usha, Shriram, Dr. Pushpa, Dr. Ravisha, everybody. It's because of you we are here, ma'am. Thank you so much. Dr. Rushma ma'am is there, Dr. Shobha ma'am. And once again, happy Holi and happy Women's Day. And thank you, Dr. Chaddha, IO officials. Dr. Atul is not there, Dr. Chaddha, Dr. Anup, Dr. Naveen, Thakkar. Thank you, Ortho TV. And thank you all speakers. And once again, living healthier lives everywhere, every day is the key. Power, privilege, and priorities, they embrace equity in women's healthcare. So our health is very important, and it's never too late to focus on our well-being. Thank you so much for joining. And we'll again.
Thank you, Aarti.
Thank you.
Thank
Happy
you.
Women's
Thank
Day.
you. Thank you, Aarti.
Thank you, everybody. I thoroughly enjoyed
Happy
it. Thank
Holi
you,
and
everyone.
happy
Happy
Women's
Holi.
Day, everyone.
Thank you, Dr.
Thank you.
Pooja.
Thank you
Bye.
all.
And everybody.
Everyone.
Thank you.
Bye.
Bye.
Thank you, Dr. Ram. Thank you, Dr. Sonali, Dr. Chasanal, Dr. Neha, Dr. Ritwika,
Bye,
Dr.
Aarti.
Saraswati, Dr. Emel, Dr. Chasanal, bye.
Bye,
Dr.
bye.
Samu, thank you so much. Thank you, Dr. Shriram. Thank you, Rishi.